Hi, I'm Peggy Krause, and we're going to talk today about how to interpret your lab report results. So, I have been in cardiac rehab for 25 years now, and I'm a diabetes care and education specialist, and I've seen lots and lots of lab reports and interpreting cholesterol and glucose. Those are my specialties. So that's what we're going to talk about today. And if when we go through these numbers, if you realize that maybe your numbers are too high and you would like to get them down, because remember that cholesterol numbers and glucose numbers that are high, they increase your risk for heart attack, stroke, blindness, kidney failure, and also amputation. So I encourage you, if your numbers are even just a little higher, let's nip it in the bud now, and you'll be able to sign up for one of our Jumpstart programs, which is coming up. So I encourage you to go to our website and check out the upcoming dates for Jumpstart 360. Okay, let's start. So when you go to the doctor and your doctor writes you a prescription for lab testing, you can expect that your doctor wants to see your cholesterol levels, wants to see your glucose levels, and other things that would be customary, vitamin B12, vitamin D, and also your thyroid function testing. So we're not going to really go into the last three, the B12, the D, and the thyroid, but I just wanted to mention them because they are really important as well. And certainly B12 and vitamin D deficiencies are easier to address. And if it's just a blood test to figure out what your levels are, might as well do it. So let's talk about lipid panel. Okay, that's the test, the battery. Actually, it's one test, and there are 4 elements to the test. That's what's going to tell you what your cholesterol level is. And there are so many particles to that cholesterol. There's so many elements in a cholesterol in testing that, but we're only going to talk about the most common 4 here. So that's total cholesterol, LDL cholesterol, HDL cholesterol, and triglycerides. So let's do one at a time. So total cholesterol, what the guideline is the national guideline, which probably your doctor does follow. They say that desirable total cholesterol levels are under 200. That 200 to 239 are borderline high, and 240 and above are high. So what does that really mean? Well, it just means that the national guidelines want your cholesterol to be desirable, that they want you to have cholesterol levels of under 200. But do we know that's optimal for good health? So let me just give you a couple statistics. So in the Framingham Heart Study, which is a study that's been going on for years and involved hundreds of thousands of people, 35% of people with ischemic heart disease, I'll tell you what that is in a minute, 35% of ischemic heart disease occurred in patients with total cholesterol levels between 150 and 200. Ischemic heart disease is lack of blood flow to the heart. When there's lack of blood flow to the heart, that can easily result in a heart attack, bypass surgery, atrial fibrillation, and more. Not a good thing, folks, to have ischemic heart disease. Do people live with it? Yeah. Is it optimal? No way. Okay. So if 35% of people who have ischemic heart disease have desirable cholesterol, how can that be optimal? Optimal to me would be cholesterol levels under 150. That's the level we know that people do not have heart attacks, right? So, and it's not just a one-time 150 cholesterol level. You need to reach that under 150 and sustain that to be considered heart attack proof. That's Dr. Esselstyn's phrase for having a total cholesterol level low enough that you don't have to be afraid, that you could be one of these 35% that even though your cholesterol levels of what are called desirable, that you could still have a heart attack. And we know that 40 to 50% of heart attacks, first heart attacks in people, are fatal. So 50 to 60% never live to see a chance for either living a healthy life or having another heart attack, which many of them do. So again, the optimal range for total cholesterol, less than 150. So if your level is a little high, now's the time to get down. Okay, LDL cholesterol, what is that? So LDL cholesterol is the low density lipoprotein cholesterol. And what does that mean? In short, that's the bad cholesterol. It's the lousy cholesterol. It's the cholesterol that winds up being oxidized in the blood, right? It changes sort of shape, changes function, it changes how, what it does, and the artery wall sucks it in and makes plaque, right? So having LDL cholesterol in the bloodstream, not a good thing. The national guidelines say keeping that LDL level under 100 is desirable. So how about this? If it's so desirable, how come almost 75% of heart attack patients fell within the recommended targets for LDL cholesterol? If it's so desirable, why do 75% of people have LDL levels that are desirable? It's just not optimal. Optimal, less than 80 if you don't have cardiac disease, or 70, less than 70 if you do have heart disease. I've even heard that the American Heart Association is looking to have 60 as your LDL cholesterol. HDL cholesterol, the happy cholesterol, the good cholesterol. Well, there's a big problem here. And you probably have heard that you've gone to the doctor and maybe your LDL or your total cholesterol is high, right? That's a problem. But the HDL is also high. So the doctor says, nope, because your HDL cholesterol is high, there's no problem here. So the job of the HDL, and this is why your doctor can rationalize this, the job of the HDL is to latch onto the LDL and carry it out of the bloodstream. It's sort of the transport mechanism. We call it reverse transport, reverse LDL transport. The HDL latches onto the LDL molecule and carries it out of the bloodstream. Well, that's a good thing. But here's the problem, is that how many people in our society are overweight, obese, smoke, stressed, have diabetes? All of those things render the HDL, make the HDL useless. So unless you are lean, don't have diabetes, don't have high blood pressure, don't smoke, have no stress, and sleep well, then your HDL is probably working. You know, and then if you have that kind of a lifestyle, your LDL, your total cholesterol, is probably not high either. So you don't need that HDL. So it's almost like it doesn't matter what your HDL is, because you don't really know if it's working. And if you have any one of those risk factors, any one of those lifestyle habits, it's not working probably. So it's not protective. Here's a fact. So in disorders such as chronic kidney disease, which most Americans have, at least stage 1 or 2, and doctors don't even tell people if they have stage 1 or 2 kidney disease, because you don't really need to intervene, so to speak, until stage 3, right? So the doctor doesn't say anything and just hopes that things improve. But stage 1 and 2 kidney disease, that's enough to make the HDL useless. If you have any form of cardiac disease, high blood pressure, atrial fibrillation, heart disease, that is also enough to make the HDL ineffective. So there is a study done in 2020, just last year, and the researcher is quoted to say that the numbers showing HDL values are meaningless. Triglycerides. What are triglycerides? Triglycerides are circulating fats in the bloodstream. So when you take in more calories than you need, the body packages those calories as triglycerides, and then if you don't use them up, the body's going to store them, usually as fat, on the body. So it's either going to be on your belly, on your hips, or wherever it's going to be, or it's going to be stored in your liver, in your muscle cells, in your pancreas, in your brain, all places where that doesn't belong. So trick number 1 is don't overeat, right? Keep active. But the triglycerides, we want that number to be under 150. And the numbers will bounce around a little bit. If you took lab tests at different points in the day, those numbers can be totally different, because again, they're circulating fats in the bloodstream. Again, under 150 is where we want them to be, and anything higher than that, I suggest you start working on it, because in the last 5-10 years or so, we have found a significant link with circulating triglycerides and heart disease. Okay, let's move on to glucose testing. There are 2 tests in particular that are done commonly. There are others that we use to test glycemic control, we call it. But the one is a fasting glucose. And that's a number you'll see under the comprehensive metabolic panel. Glucose, it'll say. And a good number is somewhere between 65 and less than 100. So that is considered normoglycemic, euglycemic. Anything 100 to 125 is considered prediabetes. Anything 126 and higher, full-blown diabetes. So having been around a while, I've seen numbers on a laboratory report. They usually somewhere between 70 and 350, 500 I've seen as high. That requires immediate attention. But these numbers are in the low hundreds, in the low 100s. Your doctor might not even say anything. Maybe it's 106, 108. Doctor's probably not even, might say, oh yeah, your sugar's a little high. Watch your sugar. That ain't gonna do it. That's not gonna lower your blood sugar. That's a whole nother story. That's something you can learn more about in our programs. The other test that we do commonly to check for diabetes and glycemic control is the A1C test. So A1C is is a measure, it's an average, a 3-month average of what your blood glucose levels were in that time. And the A1C is interesting because it measures how sticky the red blood cells in the bloodstream have become if the glucose is high. So if your blood glucose is high, all the components in your bloodstream, right, will also get sticky from that. So the red blood cells live about 3 months. So in that 3 months, they become sticky, and then red blood cells naturally die off after 3 months. So that is why we use it as an average, a 3-month average. And it is reliable, but it is not diagnostic because, and I'm going to go back to that diagnostic in a second. Again, it's an average. It doesn't show us how high those glucose numbers could go or how low they can go. It's just that average. So it's really can be misleading. So if you have an A1C of 5.5, which falls into the normal range, it might be that after meals, your blood glucose might spike up to 200. And that's not good. To have high levels of blood glucose, that damages the small blood vessels in your eyes and your kidneys and your feet. So you don't want high blood glucose. You don't want high blood glucose at all. We know that in increments that go up, that increase A1C, right? Numbers that are higher than 5.5 significantly increase your risk for all-cause mortality, dying from any cause, right? So 5.5 is really the highest you want it to go. That even short periods of elevated blood glucose increase your risk for dying of any cause. Yeah, it's your eyes, your kidneys, and your feet we're talking about, but even not more importantly, let's say also it's your heart and your brain and your lungs and every cell in your body that touches the bloodstream. It's almost like there are shards of glass circulating around in the bloodstream. So you want to keep your glucose levels down, right? You want to keep your cholesterol levels down. As cholesterol goes up, so does your risk for stroke, heart attack, many forms of chronic disease. Again, if you have found that your blood values are elevated, now is the time to work on it. Don't wait 6 months and just hope it's going to get better. It's not going to get better. I want you to go to our website, wfeh.org. Go to programs. Go to Jumpstart 360. We have upcoming programs. We can help you to reduce both cholesterol and A1C. And we will show you how the most strategic, the most effective, the cutting edge technology, cutting edge methods to lower those numbers. And it's wonderful that our 3-step strategy works not only to lower cholesterol and blood glucose, but it also improves sleep, it decreases inflammation, it works on a lot of things that cause chronic disease. So thank you for joining me, and I'll see you again. Bye.